Our next speaker comes to us from the Mayo Clinic in Rochester. Dr. Derek Lomas is a focal therapy expert who has done IRE and HIFU, and he's going to talk to us today about his experience with that.
Great, so we'll be talking about systematic biopsy in comparison to perilesional biopsy and lesional targeting in the setting of focal therapy. I have no relevant disclosures. I also want to start with a patient case. This is a gentleman that I saw not too long ago, 50-year-old gentleman, PSA 5, had an MRI with a PIRADS 4 lesion in the right peripheral zone. And what's the optimal strategy to biopsy this gentleman, to make the diagnosis, to accurately grade him, to leave options open, and also to minimize morbidity and reduce overdiagnosis of potentially clinically significant disease, insignificant disease. And there's a number of biopsy strategies out there. Of course, the classic has been the systematic biopsy, 12-core transrectal or 10-core transrectal, or systematic transperineal templates that are becoming popular now. And then there's targeted biopsy, which has become a standard for many of us, 2 to 4 cores generally directed at a lesion, either through MR fusion, cognitive targeting, or even in-bore MRI. More recently, the idea of perilesional targeting has become important and area of interest. We know from the Precision trial that MRI-targeted biopsy had better clinically significant cancer detection compared to standard TRUS alone, and importantly, reduced the likelihood of diagnosis of insignificant prostate cancer. But what are the downsides of leaving out a systematic biopsy? Well, work done here in the NIH looked at this, and they looked at omission of systematic biopsy and found that it could misclassify cancers, almost 9% of those with clinically significant cancers, and misclassify almost 16% that had higher risk disease. It could also miss a small percentage of grade group 2 cancers and 2% of grade group 3 cancers. In a group of patients that underwent radical prostatectomy, the risk of upgrading was lowest with a combined approach compared to targeted biopsy alone or systematic biopsy. Combined biopsy overall had a 10% greater cancer detection and led to upgrading in over 20% of patients. It's become more interesting, the idea of these patients that have a negative targeted biopsy but positive systematic cores. And does this represent mistargeting or potentially just a failure of the MRI? And this study looked at in patients that had a negative target but positive biopsy, that a lot of them had it in the same sextant, considering this consistent with mistargeting, but majority also had it close in an adjacent sextant or 2 sextants away, suggesting there's this idea of this perilesional field. And the UCLA group published on this a few years ago and found that the majority of cancers, 90% of clinically significant cancers, could be found in the ROI or within a radii of about 10 millimeters outside it. That radii was also dependent on the MRI grade, and it was inversely related. 18% of patients with clinically significant prostate cancer were diagnosed, though, by only sampling outside the ROI, and a small percentage, but 6.1%, were outside 10 millimeters, so there is still cancers out there. Another study from Nujaim and colleagues looked at a similar idea, and again found that the majority of cancers were in that 10 millimeter radius. There was no difference, though, in cancer detection with a combined biopsy and targeted versus perilesional sampling and targeted. Choosing a cutoff of 10 millimeters would avoid overdetection in almost 20% of men, but we still would miss about 5% of clinically significant prostate cancers. This group also created a model where they combined imaging characteristics and PSA density to help predict the likelihood of finding cancer outside that 10 millimeter radius. And this is something that could be an area of future research and could help us further risk stratify who needs more extended biopsies. So from a diagnostic standpoint, what does this mean? Well, it seems that targeted and perilesional sampling identify the majority of clinically significant prostate cancers. Omission of the systematic course helps reduce overdiagnosis of low risk, but we are still missing 5 to 16% of clinically significant cancers that would have been missed on targeted biopsy alone. So what does this mean for focal therapy? Well, a number of studies have looked at biopsy selection of patients and compared that to how that selection would have been when compared to whole mount. So these were prostatectomy specimens that they looked at focal therapy criteria, generally grade group 2 or 3, PSAs under 20, the typical characteristics we'd use by MRI and biopsy. And when they looked at who was eligible by biopsy and then whole mount, accuracy was pretty good, meaning they were good at ruling out who shouldn't get it and for the most part ruling in. But when we look at positive predictive value, you can see the numbers from whole mount eligible to biopsy eligible are quite different. And incorrect selection of candidates for focal therapy ranged from 35 to 50% in these studies where targeted biopsy plus systematic biopsy were done. Reasons for ineligibility: lesion crossing the midline in several of them, although for many of us that might not be an exclusion, it was in these studies, upgrading to higher risk in 30% in one study, and then to a smaller degree, contralateral clinically significant prostate cancer. Now, Choi and colleagues looked at 120 men that underwent transperineal template mapping, so a more invasive biopsy, plus targeted biopsy with a median of 29 cores who subsequently had radical prostatectomy. They had 52 eligible based on that mapping biopsy, and based on the whole mount, only 19% were no longer eligible, so lower than with the less invasive biopsies of the previous slide. Again, most due to crossing midline, but there were still some with higher grade cancer that were ruled ineligible. Now, Lee and colleagues looked at how can we, what's the impact of reducing the number of systematic cores on prostate cancer detection and also focal therapy planning. They used a transperineal saturation biopsy combined with targeted transperineal biopsy. Cancer detection rate overall was very good. What they saw was adding a full systematic template biopsy to the targeted biopsy led to a treatment plan change in almost half of the patients, and 10% became unsuitable for focal therapy. As they reduced the numbers of cores, they found they had increasing likelihood of a planned change. So overall, they advocated for a more thorough biopsy for patient selection. Let's take it back to the case. So again, this was a 50-year-old gentleman, PSA 5.1, came with an MRI, PIRADS 4 lesion on the right. What I didn't tell you is that he actually came with a biopsy as well. It came from a community center that I wasn't familiar with. I didn't have any information about the biopsy, so we actually took him for another biopsy. Targeted sampling of the region of interest showed grade group 2 prostate cancer consistent with his original biopsy. Perilesional sampling showed a mixture of grade group 1, grade group 2, and grade group 3. And then I did a systematic template with anterior sampling, and in this case did find grade group 4, anterior medially on the left. Now, is this a failure of the MRI? Is it a failure of the sampling? It's hard to know, but I'm sure glad I did his biopsy and canceled the case we had scheduled for next Friday. So there are unanswered questions. What's the optimal number of biopsies? Certainly template mapping on everyone is challenging, but where's the median? What's the significance of this MRI invisible disease that Dr. Klaas discussed earlier? Where does additional imaging, PSMA PET, come in lieu of biopsies? But I think we can all agree an accurate biopsy is important for focal therapy. Targeted biopsy alone is probably inadequate. Perilesional sampling adds to our understanding of the disease, and it can be useful in margin planning, but it seems that increasing sampling appears to decrease the likelihood of inappropriate patient selection and planning. And then lastly, consider a repeat biopsy, planning biopsy in those seeking focal therapy, especially if you're unclear of the original biopsy that was done. So, thank you.
Thank you, Dr. Lomas.
Well, any questions from the floor first?
How much pattern 4 was in that contralateral core?
Yeah, good question. So it was, I think, 10% of the core, but yes, it could have been under sampling or up higher grade than, but it was, 4 plus 4.
Yeah, I do wonder sometimes when we do systematic in an MRI bland area of the prostate, obviously the amount of pattern 4 really matters because you may be just picking up a small nest of 3 plus 4 and only hitting the 4 or something of that sort. So I have another question though for Dr. McClure. if he's
Yeah,
still.
Dr. McClure and Dr. Yu, can you come back up, please?
Please come to the stage, Dr. McClure and Dr. Alice Yu as well.
He may not be here, so.
I think Dr. McClure is not here
Looks like he stepped away.
at any reason.
All right.
Welcome back.
I won't ask any of you Dr. McClure's questions.
Okay, that's right. Please. Any questions for Dr. Yu?
I have just one question for Dr. Yu. In fact, congratulations on your presentation. It was not easy. As you said, there are more questions than answers. And I wonder if you have access to biomarkers in your daily practice or not. And if you don't, what are your thoughts on their use in daily practice?
Thank you. So, yeah, I think there really is a lack of data when it comes to the routine use of biomarkers. The only one that I would use from time to time is just Decipher to help me determine and risk stratify whether or not to treat the patient.
Are you contributing to the GRID database as well? Okay. The GRID is a Decipher project where they're looking at 1.4 million signals. So at some point, that might be something to contribute to. I'm also wondering, do you use ExoDX at all, or any exosome marker?
Not in my practice, no.
Not at the moment? Okay.
Well, I think one of the key questions is the sampling. When talking about focal therapy, Dr. McClure has shown us that, and it's our experience, that we are using PSMA usually for staging patients with high grade. In those patients who are candidates for focal therapy, we are facing a problem in our practice. They have undergone an MRI, a fusion biopsy, a high grade that can be a very good candidate for a focal therapy, and then we perform a PSMA, and the PSMA will look to a new lesions unsuspected. And what we do in our multidisciplinary team, re-biopsy these patients or not. We are facing this problem when we try to select high-grade patients, grades 3, that can. In the other side, regarding a genetic marker, it depends on itself and then the sampling, because you can take the sample from the other side. So, Dr. Lomas, always we are finishing in sampling. And sampling means targeted, perilesional, and in the other session, Dr. Claude defended not to perform a systematic biopsy. And what are these finishing? What do you think about?
Yeah, I think there's a lot of unknowns out there, and it's questions you want to know now or do you want to know down the line if that cancer is going to turn into something. I think it's nice to know up front. I think, when I have patients come to me, if they've had an external biopsy, unless it's from one of you, maybe they saw and you did their biopsy and did it with focal in mind, I tell them, we should really re-biopsy you, because your doctor, when he did this biopsy, their question was, do you have cancer or not? What's the grade? But they were probably going to take your prostate out, and they don't care where it begins and ends. They don't care if it's somewhere else. MRI quality, at an academic center in Toronto is probably excellent, but if your MRI was done in the community, read by the community, so I think there's so much heterogeneity in everything that, if I'm putting my name and stamp of approval on this focal therapy, I want to know, and I plan based on my biopsy as well. I save pictures of every sample, both in the fusion software and ultrasound, and that's how I create my margins. That's how I make sure I treat enough, where I can spare to limit morbidity. So I don't think we're at a point yet, at least in this country, with most MRI readers, that we can hang our hats on the MRI is perfect and we don't need a biopsy beyond the lesion.
Any other questions from the floor? Go ahead, John.
Yeah, hi, Sandeep Gurum from the NCI. Excellent presentations. Dr. Yu, a question for you. I know most of us in clinical practice use genomic classifiers to sometimes counsel our patients regarding surveillance versus therapy. But if we want to be purists with the data, many of these genomic classifiers are validated based on outcomes of men that have undergone radical therapy. And so outside of looking at a trial, looking at men on active surveillance with genomic classifiers 10 years down the line, how do we reconcile some of this data? Are we backfitting some of this data to our men on active surveillance? And what's the risk of us finding men who do really well with low GC scores, who do really well with radical therapy, but we are pushing now more for active surveillance? And is there any other way outside of these larger trials for us to kind of find out this information of what potential harm could be there?
So a lot of great, interesting points. So the genomic classifiers have been validated with biopsy specimens, at least Decipher has been. And can you just repeat some of your other questions?
Yeah, I mean, just outside of just progression, but rather looking at other outcomes like metastasis-free survival, overall survival in these men with active surveillance. It's challenging. It's a very long outcome for that, for us to find that. So I think we retrofit that data from what we have from men that have gone through radical therapy. But I guess if there's any other way for us to find this data.
So you bring up an interesting point about metastasis-free survival and cancer-specific survival in an active surveillance cohort. The problem is that not only is it the length of time, but it's also your event rate, especially in the modern era with close surveillance, proper patient selection, imaging. The number of patients who actually metastasize on surveillance is really close to zero. So you can wait 50 years and you're still not going to find the event rate you need to find any kind of meaningful outcomes.
Thank you.
Okay, we continue.
Hi, Andre Bru from Los Angeles, USC. Dr. Yu, you made a very nice presentation. One sentence you said was very interesting for me. You said, your marker is as good as your sample. This is overall how I think, but people who advocate for these markers, many of them overall, they say that's not the case. They say if you have a marker that is saying high-grade disease, this disease may be somewhere else in the prostate. Like, let's say you biopsy the left side of the prostate and it's lesion 6, but it's high-grade, and then they will go ahead and do prostatectomy on this patient because should have high-grade disease somewhere. What do you think about this?
I think for me, my bigger concern is the opposite situation where on my biopsy, I have a low risk genomic score, but there could be higher risk disease somewhere else that I just didn't biopsy. But to answer that question, I mean, from personal experience, I've performed prostatectomies on 2 patients with low risk disease. I pretty much never do, and I spent a really long time with the patient talking about risk benefits. And both of these patients, we ended up doing, it was the genomic classifier that actually pushed them to surgery, and they actually both got upstaged, actually. Neither had any imaging findings that suggested there was higher grade disease. So it's possible, but with that being said, that those patients still could have been followed on active surveillance for extended period of time, and it probably still would have been okay. It was very low volume, significant disease, but they were upstage.
Well, we have Dr. Claude. It's worth hearing you.
Well, I just wanted to make one comment about this debate about systematic biopsies, which really wasn't the focus of my talk, but I do think they are going the way of the dodo bird and should. And part of the reason I believe that, if you look at the whole oncology field, until recently, prostate cancer was really the only cancer site that did not base management on the image. Every other tumor site, kidney, breast, bladder, liver, brain, lung, you name it, it's image-based. They don't do systematic biopsies. The lung cancer people do not do systematic biopsies. The lung, breast cancer people don't do systematic biopsies. The breast, you can go down the list. We are unique in this commitment to systematic biopsies, and I think it's because of how we got here. We got here with systematic biopsies. But now we have the image, and I think it's time to join the other tumor sites in accepting the limitations of the image, because I agree it's not perfect. But despite the fact that it's not perfect, we don't need perfection in medicine. We need good, excellent. If we demand perfection, we're demanding too much. So.
Well, but all tumors are based on images, and maybe these are leading us to PSMA as maybe a better way to select those, at least those significant cancers. No? Well, I think we have more question, and of course.
Yeah, John Feller, this is also a question for Dr. Yu. Just sort of, have you thought about expanding your thinking about the biomarkers? Your lecture was really focused appropriately on the risk stratification of men for focal therapy, but sort of the larger thinking about, NCCN guideline-driven germline genetic testing, polygenic risk scores, which aren't really yet baked into guidelines, but have an emerging role in terms of sort of growing the pie overall of men we're identifying, with early detection and sort of pivoting from age-based screening to risk-based screening. So do you utilize, germline genetic testing and or the polygenic risk scores in your practice?
Yeah, I think that's a great question. And I do think, speaking about germline genetic testing, I do believe that actually in the Falcon consensus BRCA, patients with BRCA genes, or I guess there was a consensus against focal therapy in that patient population. Most of these patients who are candidates for focal, a lot of times that risk category that we're dealing with are sort of that favorable intermediate risk. So based on guidelines, unless they have a really significant family or personal history that's, where germline testing is indicated, if they are just an isolated case of prostate cancer, favorable intermediate risk, I don't think there is an indication really for germline testing. So it's not something that I do routinely in my practice.
Well, I think we finished. Thank you very much for your attention. See you tomorrow.